Dr. Levine, I think you have 22 more seconds left in that
I'm ready. You want me to share my screen?
56 countdown, but I'm going to briefly introduce you.
Okay.
You are an assistant professor at the University of Maryland School of Medicine, and you're involved with the Critical Care Medicine Fellowship. Is that correct? Are you the program director?
Yep, exactly.
Fantastic, Dr. Levine. We may have missed each other when I was training at the NIH. I always had amazing Maryland fellows, so I feel like I just missed you. But good to have you. And from one Maryland grad to another, Dr. Levine, the show's all yours.
Thank you very much. Excellent. All right. Well, thank you guys so much for having me here today. It's my pleasure to talk about acute respiratory distress syndrome, which is far and away my most favorite topic to talk about, actually. So it's a delight to be here tonight to talk about this. So I wanted to introduce two cases tonight. So the first case is a 40-year-old patient of mine. He has end-stage renal disease, and he came in with severe abdominal pain. He localized his pain to the epigastric area and described it as a constant ache. His labs were most notable in the emergency room for a lipase of 6,400 and a white count of 20.6. He had some underlying renal insufficiency, but his creatinine was up to 2.3 and his K was 5.7. He had a CT scan of his abdomen that showed fat stranding around the pancreas and evidence of pancreatic necrosis. He quickly progressed to oliguric renal failure. His chest x-ray had bilateral pleural effusions. He had progressive respiratory failure. And ultimately, unfortunately, he required intubation. He did ultimately require ECMO, VV ECMO actually, for profound hypoxemic respiratory failure. This was his chest x-ray, so hopefully it projects clearly on the screen here, but as you can see, there's diffuse bilateral patchy opacities, really not sparing any lung field at all. And so what's the diagnosis? Well, it's not a surprise. I'm here to talk about ARDS. So this gentleman had ARDS, I think secondary to his pancreatitis. And so my task for today is really to talk to you guys about ARDS and how to define it and what are the current treatments or therapies that we have for ARDS. I thought this was interesting. So in 1967, Ashbaugh and Tom Petty described ARDS for the first time, really in our current literature. So it's been described many times before that in all sorts of different capacities, even dating back hundreds of years. But in the way we think of ARDS now, this was described in The Lancet in 1967. And they said the respiratory distress syndrome in 12 patients was manifested by acute onset tachypnea, hypoxemia, and loss of compliance. The syndrome did not respond to usual and ordinary methods of respiratory therapy. PEEP was most helpful in combating atelectasis and hypoxemia. Corticosteroids appeared to have a value in the treatment of patients with ARDS. You guys can hold on to this through the rest of my talk, but interesting that 50 plus years ago, this is exactly the same syndrome that we're describing today. So if you look at the numbers, ARDS represents 10.4% of total ICU admissions. So this is the bread and butter of what I do and who I care for in the intensive care unit. And it represents 25% of all patients that ultimately go on to require mechanical ventilation. So this is not an orphan disease. This is not an unusual disease. This is a very common syndrome in the critical care unit. This is from JAMA 2012. So this is how we currently define and then grade the severity of acute respiratory distress syndrome. So this is what we call the Berlin criteria. And I'm going to walk through each one of these, but there's 4 important criteria that we have to talk about tonight. So the first being that this has to be an acute illness. So acute meaning less than 7 days from the clinical insult or less than 7 days of symptoms. The second is that we have to have bilateral opacity. So there's a radiographic criteria to be able to call someone ARDS. And there's lots of different words to meet this radiographic criteria. So some will say it's patchy, it's ground glass, you have scattered dense opacities, it's very heterogeneous in the way it appears. And of course, it's consistent with pulmonary edema. So like the x-ray I showed you, had I told you a different clinical story, you may have said, oh, that patient has pulmonary edema. So kind of that's the pattern it looks like on chest x-ray. This is a CT scan of what I would say is kind of a classic picture for acute respiratory distress syndrome. Up here in the upper left corner, you can see there's more dense consolidations in the bases bilaterally, but there's other areas where it's more ground glass, where you can actually see through and see the blood vessels coming through. So that's ground glass. And again, it's a very heterogeneous process. So it may look different in the apices compared to the base, but this is a classic CT scan for acute respiratory distress syndrome. The third criteria, and this is the one that I really think is among the most important and also the one that's I think the least well understood, is that it has to be non-cardiogenic pulmonary edema. And this means 2 things, but I think it's often, again, misunderstood. You have to have a reasonable suspicion that it's not cardiogenic, but also it has to be pulmonary edema, right? It's not enough to be one or the other. And so what do I mean by this? So in normal cardiogenic pulmonary edema, this pathway over here where you see the heart, there's an increase in hydrostatic pressure. And this increase in hydrostatic pressure occurs because your volume overloaded or your left heart doesn't work. And as a result of this, you end up with fluid, water in the alveolus. And that's what pulmonary edema is, right? But in contrast to that, in ARDS, you have a capillary leak syndrome that's happening. So here's your alveolus, and here's your capillary, and you have the capillary that's become leaky. And as it becomes leaky, you have different cells, different fluid exiting out of the capillary, entering into this interstitial space and ultimately into the alveolus. And so you end up with fluid in the alveolus, but it's not cardiogenic. So it is pulmonary edema, but it's not cardiogenic. And that is critically important to making the diagnosis of ARDS. We're going to talk about direct and indirect injury in a second, so I'm going to skip through that. This picture is seen in every paper about acute respiratory distress syndrome in some variation or another. I'd be remiss if I didn't include it in this talk. But so here's a normal alveolus. And you can see here there's type 1 alveolar cells that are here. There's a very thin epithelial basement membrane. You have some type 2 cells that are here as well. Again, you have a very thin interstitium here that separates the alveolus from the capillary. This is what allows gas exchange to happen, this very thin layer that is here separating the alveolus and the capillary. But in ARDS, you have an entirely different situation, right? So you have sloughing of this bronchial epithelium that's happening. And so where you had this very nicely organized layer of type 1 cells are now sloughing into the alveolus itself. You have this capillary leak that's happening. And so you can see here areas where the capillary is allowing cells to exit the capillary and enter into this interstitium, which is getting wider and wider and wider. You have neutrophils and macrophages that are actually entering into the alveolus. And in doing so, they're releasing these inflammatory cytokines that themselves are triggering more cells to come into the alveolus that are triggering more cells to release inflammatory cytokines. And what happens is this toxic milieu of inflammatory cells and inflammatory cytokines. So it is not water, but it is fluid in your alveolus. And so herein is the essence of non-cardiogenic pulmonary edema. And this is the pathophysiology of ARDS. So what causes this non-cardiogenic pulmonary edema that I continue to talk about? And so we divide these causes into direct and indirect causes. So direct are things like pneumonia or aspiration of gastric contents and inhalational injury, pulmonary contusions, things that directly impact the lungs themselves. And in doing so, cause this capillary leak. But there's also indirect causes. So remember, our patient had pancreatitis. He had nothing actually wrong with his lungs to start with, but in the setting of his inflammatory pancreatitis, he developed an indirect acute respiratory distress syndrome. And there's other things that fall in this category too. So non-pulmonary sepsis, so a urinary source of sepsis or a bloodstream source of sepsis can cause ARDS. Burns, non-cardiogenic shock, drug overdoses, and lots of issues with blood transfusions. So transfusion-related acute lung injury is a form of acute respiratory distress syndrome. So this is what causes non-cardiogenic pulmonary edema. And then the last criteria really is not just a criteria to make the diagnosis of ARDS, but allows us a way to stratify how severe the patient's acute respiratory distress syndrome is. So patients have to have a P to F ratio of less than 300. And this is your PaO2 divided by your FiO2, and less than 300 is mild, less than 200 is moderate, and less than 100 is considered severe. So it's not only part of the diagnosis, but part of the stratification of severity. So we talked about what is ARDS, but what is not ARDS? And so processes that cause hypoxemia and cause diffuse ground glass opacities are not all ARDS, right? There's lots of things that can cause hypoxia and lots of things that can cause your radiographic finding that aren't ARDS. And those things are things like eosinophilic pneumonia and alveolar hemorrhage and lung cancer and Kaposi sarcoma. And those are not ARDS because if you have blood in your alveolus, this is not non-cardiogenic pulmonary edema, it's blood, right? So there's lots of things that are not ARDS. And if you're interested in this, Roy Brower has done a lot of work on this and has a nice paper that you can look up about what he calls ARDS mimics, and there's a whole list of them. I think we've spent a lot of time because of the Berlin definition and because that in general, I think we're lumpers as clinicians, lumping together a group of homogeneous different diseases. And we talked about direct and indirect causes of ARDS, and we've lumped them all together and called them ARDS. And in doing so, we've developed the syndrome called ARDS, and we put people together who have similar pathophysiologies. But I think it's really important to remind everyone that ARDS is a syndrome. It's not a specific disease process, it's a syndrome. And so what do we actually get by labeling a patient as having ARDS? Well, we don't have a known treatment, and maybe we're putting together a group of people who make up a more homogeneous population, although I'll argue in a minute that that's probably not true. We think we should use low tidal volume for people who have ARDS, and that certainly is true, but I also think we should use low tidal volume for probably everyone at this point, so I'm not sure that that's that important. Maybe the most important reason to label someone as ARDS is it forces us to take a step backwards and think about all the things that cause this acute respiratory distress syndrome. And when we do that, we can think about how we treat those different causes. For example, a urinary tract infection that may be causing ARDS or pancreatitis. But what do we lose by labeling a patient as ARDS? I want to talk for just a brief second about all of the failed pharmacotherapeutics for ARDS. And this is a very short list compared to how many failed pharmacotherapeutics we really have. And the reason I bring this up is that more and more people think that the reason these pharmacotherapeutics are failing is because we've lumped all these people together who maybe share some degree of a pathophysiology of this non-cardiogenic pulmonary edema, but maybe these are really not all the same process, right? And so maybe we should split them and stop lumping them together so much. And I'll show you a little bit of data to support that argument. So this is work done by Carolyn Calfee, and this work really looks at whether or not there's two distinct phenotypes of acute respiratory distress syndrome. So hopefully this comes through okay, but if you look at the red line, this is what is called phenotype 2, or an inflammatory phenotype. And the blue line is the non-inflammatory phenotype. And if you look at the red line, and if you can read the axis at the bottom, the x-axis, you'll see that the phenotype that's inflammatory has a tremendously higher level of things like interleukin 6 and interleukin 8 and TNF1. And these are inflammatory cytokines. And then if you follow this line down, you can see that they have a much lower P to F ratio, lower albumin, lower platelets. These patients are sicker. And this is in contrast to this non-inflammatory phenotype, which has lower inflammatory biomarkers, which makes sense, but also has higher levels of things like P to F ratio, and they're a little bit less sick. And then if you look at the mortality in these two different phenotypes, they're vastly different, right? So I told you that phenotype number 2 is the inflammatory phenotype, and phenotype 1 is the non-inflammatory phenotype. The 90-day mortality in phenotype 2, the inflammatory, is 45%. And the 60-day mortality is 45%. And there's very few ventilator-free days. And this is in stark contrast to the non-inflammatory phenotype, right? Where the mortality is 21% at 60 and 90 days. So maybe these are two different disease processes, the inflammatory and the non-inflammatory phenotype of ARDS. Okay, Andy, we're kind of with you, but why does this actually matter? What about all these drugs that we failed? What about all these pharmacotherapies that we've said failed for acute respiratory distress syndrome? So if you look at the two blue lines up here, these are the hypoinflammatory phenotype getting simvastatin, which is a drug I told you failed. And there's really no difference between the placebo and the drug in the hypoinflammatory patients. But if you look at the hyperinflammatory patients and you look at the red line compared to the orange line, there is a difference in survival in these patients. So maybe simvastatin failed because we grouped together people who had hypo and hyperinflammatory phenotypes, and then we said the drug failed. But if we think the drug is an anti-inflammatory and makes the most sense to use it in an inflammatory phenotype, maybe we should have excluded all of these blue people and really just trialed our drugs on the red and orange people, and maybe the drug would have succeeded. We would have said this drug works in an inflammatory phenotype of ARDS. So there's more and more data to suggest that there's certain phenotypes and that we should use precision medicine to really define people as inflammatory or non-inflammatory. And then we should perform clinical trials to see if drugs succeed or fail in the correct phenotype. But for now, we have a long laundry list of drugs that have failed. So currently, there are no actual treatments for ARDS. There's no silver bullet. There's no medicine I can give my patients who have ARDS. But there are a bunch of interventions that are critically important to know if you're going to care for patients who have acute respiratory distress syndrome. So the first intervention I think to mention is the low tidal volume ventilation. So this is from the ARMA trial. This is from the New England Journal from 2000. They looked at patients who got low tidal volumes, which is 6 cc's per kilos. They compared them to patients getting higher tidal volumes, which is about 12 cc's per kilos. If you look at the people who had lower tidal volumes, they're seen in the solid black line here. If you look at the traditional tidal volumes, they're seen in the dotted lines here. And if you look at the survival, you can see there's a difference in the survival of these patients, where the people who have lower tidal volumes have a higher survival compared to the people who have higher tidal volumes. And the same thing is true about discharge. So they're more likely to be discharged. So we think that lower tidal volumes are better. And you can see this over here in this table 4 as well, that in terms of the death before discharge, people who had a lower tidal volume were less likely to die. They were more likely to be breathing without assistance. They had fewer ventilator-free days. They had less barotrauma. And so since then, we really abide by this principle of 6 cc's per kilo tidal volume. And as I said, there's more and more evidence that we should be doing this in all patients, but certainly in ARDS, 6 cc's per kilo is the key. I wanted to mention just quickly a couple other vent strategies that should not be ignored. So PEEP is our friend in patients who have acute respiratory distress syndromes. This is positive end expiratory pressure. A plateau pressure of less than 30 is important. Driving pressure, which is the difference between the PEEP and the plat here, we think should be less than 15. And in general, we should try to prevent ventilator-induced lung injury. So we know that the plateau pressure is important and that the higher and higher the plateau pressure goes, this increases your mortality proportion. So we kind of agree that 30 is an appropriate plateau pressure that we're willing to tolerate, but beyond that, our mortality just increases more and more. And then if you look here at the driving pressure, so we think a driving pressure of 15 here is basically where the risk of death is 1 on this multivariate risk of death in the hospital. But beyond this driving pressure of 15, you can see there's this dramatic increase in the risk of death. So this is where we get these numbers of plateau pressure of 30 and driving pressure of 15. And this is again work by Roy Brower, published in the New England Journal. He's part of this Amato group. So what about the second intervention? So prone positioning, again, from the New England Journal of Medicine. So this is the PROCEVA trial from 2013. Lots of Kaplan-Meier curves tonight for you guys to look at. But so again, if you look at the prone group here, the survival in the prone group is infinitely better than the survival in the supine group, right? So we gain a lot in terms of survival looking at 90-day mortality in people who we prone. And this was just an infographic that I saw actually on Twitter today that Chest was providing, but just looking at prone positioning and how it works. And this is simply flipping people over onto their stomachs. In fact, in COVID times, people are self-proning is pretty common and you're hearing about that. And you can read through the physiology of why it works, but a lot of it has to do with the VQ matching, has to do with the lung compliance and the chest wall compliance. But so proning is critically important. It's a fairly low risk intervention in a hospital system or an ICU that does it frequently, and it has a proven mortality benefit. So what about fluids? So we think conservative fluids are probably pretty important. And this is the FACT trial, again, New England Journal of Medicine, 2006. So if you compare conservative fluids, which just means sort of paying attention to how much fluids you give people and not overloading them, compared to a liberal fluid strategy, again, there's a significant difference in lots of our important outcomes. So not in mortality here, but in ventilator-free days, there's more ventilator-free days in people who got less fluid. There's more ICU-free days. There's some improvement in terms of other organ dysfunction that occurs. So generally, we think that less fluid is better. And if you have to give fluid, that probably de-resuscitating these patients is going to be important to getting them overall better. All right, what about ECMO? So maybe a little bit controversial, although here at the University of Maryland, we do a lot of ECMO. So this is from 2018. This is called the Eolia trial. All these trials have funny names. But so the Eolia trial, again, a Kaplan-Meier curve here, looking at ECMO in red to control in blue. So those of you who are familiar with Eolia, you know that this trial was actually aborted early. The reason it was terminated is because there was a lack of ability to demonstrate any effectiveness in the intervention group of the ECMO group. So there were predefined periods where the trial had to be meet certain markers. I will say in support of the Eolia trial that there is a clear trend here that the ECMO group and the control group are separating out. It was very slow to enroll patients in this trial. And had they continued to enroll, it may have been significant to show that there was an improved mortality in the ECMO group. But as it was, the trial was ended early, and so there is no demonstrated improvement in mortality using ECMO for ARDS. And then steroids. So this is probably the most controversial thing, and it remains controversial in kind of all realms of intensive care medicine, but is very controversial, I think, especially in ARDS. So we're going to start here with the Lazarus trials. This is looking at corticosteroids and persistent ARDS. And the Lazarus trial basically showed no effect of steroids, no beneficial effect of steroids. So if you look at in the black dotted line compared to the pink, there was no difference in terms of your probability of survival comparing your methylprednisolone to your placebo. So these lines are totally overlapping each other. And similarly, if you look at breathing without assistance or ventilator-free days, the red and the blue line are essentially overlapping each other. So it appeared that there was no difference in this sort of refractory ARDS with the use of steroids. However, the story doesn't really stop there with steroids, and I could give an entire lecture series on this, but there's a meta-analysis that was published in SCCM that came out that looked at a whole series of different studies in ARDS that specifically looked at the benefit of steroids. Many of them are small studies, many of them are poorly designed studies, but overall, if you look at the forest plot here, you can see that there's a benefit to utilizing steroids. So the risk ratio is 0.64. That means that there's a 46% reduction in mortality with the use of steroids. So I think most critical care doctors recognize that this is a meta-analysis, that there's a lot of flaws in these studies, but there certainly is a hint that perhaps steroids are beneficial in ARDS, although there does not appear to be any benefit in ventilator-free days. So fast forward to February of this year, the DEX ARDS study comes out, and the DEX ARDS study looks at dexamethasone in patients with ARDS, gives dexamethasone for a total of 10 days, 5 days at a higher dose, 5 days at a lower dose. And for the first time in a relatively well-constructed RCT, we're seeing that there's a significant reduction in ventilator-free days, all-cause mortality, ICU mortality, hospital mortality, and duration of mechanical ventilation with the use of corticosteroids. And again, on the Kaplan-Meier curve here, you can see there's a significant difference in the curves, dexamethasone versus control. Now, this study does have issues. I'm not saying it's the holy grail of studies on corticosteroids, but it's probably the best study we have to suggest that there may be a benefit in corticosteroids. And then COVID happened, and I think that this study lost a little bit of momentum perhaps, and people got very busy with the COVID pandemic, but it was a fairly prominent study about ARDS and steroids. So what interventions have fallen out of vogue? These are things that I was doing even as a resident, which was not that many years ago, but the routine use of neuromuscular blockade. So continuous rocuronium or Nimbex strips that is not in use anymore. Inhaled epoprostenol, the use of the oscillator, rotoprone beds, all those things have fallen out of vogue. But I think if you can remember the 4 or 5 other interventions that I shared with you, then you have a pretty good grasp on how to treat ARDS. So I said I was going to share 2 case reports. The second one, now it's May of 2020. I have a 49-year-old who shows up. They have a past medical history of obesity, AFib, and diabetes. They come in with cough and shortness of breath. They have progressive hypoxemia. They require initially high flow nasal cannula, and then they're intubated. Their oxygen saturations are very low, despite being on 100% FiO2. Their chest x-ray looks very bad, similarly bad to the first patient. Again, diffuse opacities involving all lobes of the lungs, kind of a ground glass appearance with maybe some more dense opacities at the bases. And this patient has COVID-19, okay? So COVID-19 is a form of ARDS. Now, this figure is not really that different than the initial figure I showed you of the alveolus, where half was normal and half was abnormal. This is the pathophysiology and the biochemistry involved in COVID-19 ARDS. What we know is that the virus impacts these type 1 and type 2 pneumocytes, actually preferentially probably the type 2 pneumocytes. And in doing so, it results in the release of all of these inflammatory markers, like I said, IL-6 and IL-8. These inflammatory cytokines are then going to recruit monocytes, macrophages, and neutrophils, dendritic cells, which are going to traverse this capillary that becomes leaky, enter the cell, release more inflammatory cytokines, and sort of this spiral of doom happens, where you get, again, non-cardiogenic pulmonary edema. It is not very much different than what I showed you at the very beginning. And this is maybe one of my most favorite slides, which is that COVID-19 ARDS is ARDS. So whatever you hear on Twitter or read on your Facebook about it's a different kind of ARDS, it's not. It's ARDS. And I look to these editorials often during the COVID-19 pandemic. So they're both in the Blue Journal about first do no harm and looking at the defense of evidence-based medicine, because I think it really is our obligation as doctors, as nurses, as practitioners to first do no harm and make sure everything we do is for the benefit of the patient, but also to rely on evidence-based medicine. And we have more than 50 years from the time of Tom Petty and Ashbaugh of looking at how to treat ARDS and having good evidence-based medicine. And we should not forget that just because we have not seen SARS-CoV-2 virus before. So especially in times of chaos and pandemic, we should rely on the things that we know. And that's a lot of evidence-based medicine that already supports what to do in acute respiratory distress syndrome. And just to prove that it's not different than other kinds of ARDS, this is some work done by Carolyn Calfee just this year in Lancet. This is looking at different Apache scores, as well as things like soluble TNF, creatinine, the biomarker IL-6. And if you look at COVID patients in the left column compared to non-COVID respiratory failure patients in the right column, there's not a whole lot of difference. So in terms of inflammatory markers and platelets, creatinine and soluble TNF, there isn't a whole lot of difference that this is different than other kinds of respiratory failure. And interestingly, we have an entire therapy of COVID-19 drugs attempting to target IL-6. We really don't even have evidence that IL-6 is unique to COVID-19. So just interesting, again, COVID-19 ARDS is ARDS. But I do feel like I need to just quickly mention two important trials that have come out in the wake of COVID-19 that I think are specifically helpful and guide us in how to treat these patients. And this is the trial ACT-1. This is looking at remdesivir for the treatment of COVID-19. It's remdesivir compared to placebo. And what we saw is that looking at all comers, remdesivir showed a benefit in terms of the patients who recovered. And so patients recovered more quickly with remdesivir than they did with placebo. I think a reduction from 15 days to about 10 or 11 days with placebo. And this benefit is really seen most in people who are receiving oxygen, whatever this means, but receiving oxygen. And the benefit is really lost in people who are on high flow nasal cannula or non-invasive mechanical ventilation, and is essentially entirely lost in people who are on mechanical ventilation or ECMO. So while the subgroup analyses are probably not powered to give you a true answer here, the drug appears to be the most helpful in this kind of receiving oxygen, but not critically sick, needing to be on mechanical ventilation. And then more recently, the Recovery Collaborative Group, which is a group that's studying multiple different drugs in COVID-19, studied dexamethasone. They came out with what's called the Recovery Trial, and they showed a benefit of dexamethasone in patients with COVID-19 ARDS. So again, looking at all comers, which is what the trial's powered for, usual care has worse mortality. Dexamethasone has an improved mortality. There's a rate ratio of 0.83, which means a 17% reduction in mortality in patients who get dexamethasone, but also it's really subgroup dependent. So if you look at the people who are on oxygen only, there's maybe some benefit here, right? And if you look at the people who receive no oxygen, the curves actually flip where it looks like there's a harm to dexamethasone, which I think is interesting. Then if you look at the people who are the sickest on invasive mechanical ventilation, these are the people who really get the most benefit from steroids, right? Their risk reduction here, their rate ratio is 0.64, so they have a 46% less likely chance of having mortality over the 28 days compared to people who did not get dexamethasone. That's pretty impressive. Probably not powered, again, just for the subgroup, but a pretty impressive finding of dexamethasone in COVID-19. So I think, like many things, what you're going to find here is that it's about not just the right drug, but the right drug at the right time, right? And so probably in this early phase, you're pre-symptomatic, and at the pre-symptomatic phase of COVID-19, your viral load is going up and up and up and up and up. And as your viral load goes up and up and up, eventually you get to a point where you're symptomatic, but your symptoms are mild at first with maybe cough, maybe dyspnea. This is the place where remdesivir, I think, was the most effective. In these mildly symptomatic people who were on some degree of oxygen but were not mechanically ventilated, because it's an antiviral drug, right? It targets the virus itself. So here is where remdesivir is probably the most effective. In contrast, as your immune system starts to ramp up and says, this is a foreign thing, I have to attack this, your immune system ramps up, and as it does, your clinical symptoms progress and get worse and worse and worse. And as we talked about many times, ARDS in many ways is just a dysregulated immune response, right? It's this hyperinflammatory immune response with all these inflammatory cytokines. So as your immune response goes up and up and up and up, you end up hospitalized with worsening shortness of breath, and ultimately sort of the end stage of dysregulated immune response, which is this ARDS. And it's here that we think steroids is the most helpful. In the recovery trial, they actually specifically look at that patients who are symptomatic for more than 7 days got the greatest benefit out of steroids. So this is really this part of this graph here, of this figure, in these patients who the viral genome is coming down. If you could quantify the viral load, you may find it was coming down, but their immune system is ramping up. And that makes sense because that's how steroids works, is they're an immunosuppressant. So I think it's not just finding the right drug, but it's finding the right drug and figuring out when is the best and the safest time to give this drug. So after flying through that, what are my most important takeaway points? I think it's critically important to learn to recognize ARDS, but accept that it's really just a construct to guide your thinking, to get you to start thinking about what kinds of things cause non-cardiogenic pulmonary edema, cause capillaries to leak, what's in my differential diagnosis, what kinds of things can I target that actually do have therapies that could make a difference here. I implore you to remember that not every hypoxic patient has ARDS. There's lots of other things that cause hypoxia. Practice good evidence-based clinical medicine, right? We have lots of clinical trials over many, many years that guide us in how to care for these patients, COVID-19 or otherwise, and read those trials and practice good medicine. And then maybe most importantly, especially right now, enroll your patients in high quality clinical trials. Very well constructed, randomized controlled trials that are sponsored by good high quality institutions, because especially in COVID-19, this is the only way that we're actually gonna get answers to what are the best treatments for our patients. So please enroll your patients in these clinical trials. And I think that is it for me.
Well done, Dr. Levine. Excellent.
Thank you.
And I'm going to actually ask the leadership, should we take questions now or dive into the second half of this? We take questions. Go ahead.
I think Dr. Levine needs to go, so maybe dive into it now.
Fantastic. So if you guys have questions, you can either put them into the chat box where I will read them off in Morgan Freeman-like fashion, Dr. Levine, or you can request to be unmuted and we can go ahead and do that for you guys. Dr. Levine, actually, as people are wondering what questions to ask you, let me go ahead and just, I love that you emphasized about COVID-19, because clearly that's what we're all discussing, and ARDS. And you know, I always like to just kind of ask people from their own clinical experience. I mean, from your standpoint, is there any kind of nuance that you feel is unique that stands out? I say this because for my practice, I just feel like at some point I just realized I'm just managing ARDS and it just happens to be from COVID. But what are your thoughts?
Yeah, I find the same thing. I think that I think it truly is ARDS. I think maybe this phenomenon of this happy hypoxic, I haven't seen it as much before in like influenza, for example, where people are on the phone having a full conversation with their loved ones, and yet their oxygen saturation is reading 85%, and requiring 100% oxygen. So I think this kind of happy hypoxic. Martin Tobin actually has a really nice piece kind of explaining the physiology between the happy hypoxic. But aside from that, I agree with you. This is ARDS, you know, whether it's influenza or COVID-19, it is ARDS.
Perfect. And so someone wrote, so this business of L and H phenotype and COVID ARDS, Dr. Levine, it sounds like you do not subscribe to that. Is that correct?
I think there probably are different phenotypes of COVID-19 ARDS. I think there's probably different phenotypes of all ARDS. But I do think that it still is, as far as we define it right now, acute respiratory distress syndrome, and that there may be diffuse ground glass opacities. I think that very few of the patients, when you actually are able to measure their compliance, have normal lung compliance. I think a compliance of 30 and 40 is not normal. It may not be as bad as we see in influenza, but it's not normal. So maybe there are different phenotypes, but I still think, at least using the definition we use now, it's still all ARDS.
I'm going to second that. I agree with Dr. Levine. We just have a new player to the table, SARS-CoV-2. It gives us a syndrome that we have, 60 plus years of insight into. So I agree with you as well, Dr. Levine. George Lawrence writes, where does monoclonal antibody fit in in the treatment of COVID-19? If you want to take a stab at that, go for it, Dr. Levine.
Yeah, it's a really good question. So there are some studies that have already studied monoclonal antibodies. Actually, Eli Lilly had a monoclonal antibody that they were trying to bring to the market. The preliminary data on Eli Lilly's product was that it was failed in COVID-19. It's actually to be studied in the randomized control trial of Active 3. It was taken out of Active 3 because of negative data. I think there's additional monoclonal antibodies that are being developed because it makes sense. It makes good sense why they would work. Obviously, we know that there's excuse me, cocktails of monoclonal antibodies that some people are using as well. So I think there will be more to come about monoclonal antibodies. But for now, there is not a monoclonal antibody that is a magic bullet for COVID-19 ARDS.
And so would you, if I can try to summarize that, and Dr. Levine, tell me if I misrepresent what you said. Monoclonal antibody in the algorithm fits in if someone is actively recruited for research, but it is not part of the go-to therapies right now for us.
Correct. I think that's dead on. And I do think, just to spend 1 second in reflecting back, I've seen a lot of these COVID-19 patients as they've come into my clinic. They survive illness, they survive critical illness and ECMO. And I look back at what we did to treat them in March and April, and in some ways you're shocked. Like, we were giving hydroxychloroquine and zinc. We had no real data to support that. It didn't physiologically make a whole lot of sense. And you almost are shocked and embarrassed now that you were doing that. And I think, to your point, is that we need to enroll patients in clinical trials, because everything else is just sort of following the lead of your friend on Twitter and figuring out what to use to treat these patients. There are many, 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 many really well executed adaptive trials that are going on to study these interventions as quickly as possible. And I think until we have good data from these clinical trials, all the rest of the stuff is really just noise in a way.
Yep. So I'm going to ask one last question, then we'll move on to Dr. Top, I promise, and that way, Dr. Levine, you can get on with your day. But I'm going to take a bit of an approach to this, answering this question, and you can add more if you like. Someone just asked, is there a calculator to determine where dexamethasone benefits ARDS or outweigh risks? And what I would say, and there's a great guideline at the NIH critical care guideline that's available to the public. They strongly recommend dexamethasone when ARDS is identified. It doesn't seem to be, Dr. Levine, you were going through an amazing recognition of the phenotype. I don't think they spell it out as eloquently. They just kind of identify it as black and white. I will say there's a great meta-analysis that does show dexamethasone causing harm if you're using it in patients without a hint of hypoxemia present. So I do want to advocate that. Definitely should be reserved for your sickest patients. Dr. Levine, anything you'd like to add to that?
No, I think that's correct. And I agree. The meta-analysis was in JAMA, looking at not just the recovery trial, but 7 other trials that ended their trial because the recovery trial was published. And so I agree, recovery looks like harm in those who are on no oxygen. Some of the other trials also are not showing as much benefit. So I say use it cautiously, truly use it in your patients with ARDS or high flow oxygen. But before that, I think we don't know. And that's actually the subject of other clinical trials that are currently being run, is what about that low oxygen or no oxygen group? What's the benefit to them?
Perfect. Dr. Levine, we could probably stay all night talking about ARDS and other critical care things. And I mean, I wouldn't mind, my kids may mind, but Dr. Levine, and I know your time is precious, so you are off to the rest of your evening, but I'm getting phoned or chatted by our leadership to move on to Dr. Top to talk about our second favorite organs for lung doctors, being the kidneys. They're very important too. But Dr. Levine, I'm going to send you applause on my end. Thank you so much for your time. And Dr. Top, you have to correct me if I'm mispronouncing your name. As an individual who has a linguistic nightmare of a name, you can tell that I tend to be a little bit sensitive to how people's names are. Do you mind? Let me just briefly introduce you, and you can tell me if I mispronounced your name. But Dr. Joel Top.
As a pulmonologist, it'll be beautiful because it rhymes with cough.
Oh, Top. Well, by the way, you're assuming that my Baltimore accent would translate cough in the way that you imagine it would. So that's very kind. So you are from St. Clair Nephrology, an assistant clinical professor, and at the Open University William Bellmount School of Medicine in Detroit, Michigan. Also, your Twitter handle is _boy. So we'll make sure that we follow you after this. Perfect. So Joel, the floor is yours, my friend.
Excellent. So I have a case study in hyponatremia, but we know that hyponatremia is not a salt problem; it's a water problem. So we'll switch the title slide to be more appropriate for hyponatremia. I have a number of conflicts of interest, but to make it simple, many dogs, many fights, none in today's talk. I am a perpetual procrastinator, so much so that I now own the URL sorry my slides aren't done.com, which you can go to and get a copy of the slides that I'm going to show tonight. So I have a case. It's a 70-year-old poorly nourished man. He had a recent stroke and he still suffers from dysphagia. So he went home with a peg tube to do supplemental nutrition. He has a 3-day history of altered mental status and vomiting, and he is brought to the emergency department by EMS. They find he has normal blood pressure, good perfusion. They do a urinalysis, which shows a low specific gravity and positive for everything except for epithelial cells. Here we have his initial labs, and you can see he's got I got the discharge labs from 6 weeks ago, and on admission he's got pretty significant hyponatremia, but otherwise pretty unremarkable labs. Importantly, no indications of acute kidney injury or acidosis. And as happens in the ER when patients come in with hyponatremia and dirty urine, he gets a resuscitation with IV fluids, a couple of liters of balanced solutions, and he gets a gram of ceftriaxone. And 6 hours later, his labs look even better than they looked on admission. Now, certainly this sodium has been fixed way too fast, but otherwise the labs look great. Creatinine is below his discharge creatinine. Everything's looking pretty excellent, besides that rapid change in creatinine. And so the following day they discharge him and they give him the following discharge diagnosis. They call it a urinary tract infection, they call it dehydration, and they call it hypovolemic hyponatremia, right? The argument was the patient had hyponatremia. We gave him lots of volume and his sodium got better. Hence it must have been hypovolemic hyponatremia. Now, the mechanism for hypovolemic hyponatremia, starts with volume depletion, leads to a release of ADH, a non-osmotic release of ADH. That will decrease the urine volume. And so you get this mismatch where water intake is greater than urine output. And that's the recipe to develop hyponatremia. And so I'm going to use this graph quite a bit. So just kind of, take a moment to get familiar with it. There are 3 lines. These are all 3 lines that account for different stimuli for the release of ADH. We're not going to use the purple line, which is changes in osmolality, because that ADH is released with increases in osmolality. And if we're talking about hyponatremia, we're only talking about decreases in osmolality. And so we're going to talk about the green and red lines. And if you look at the x-axis, we're going to be looking at the bottom x-axis. So the -10, -20, and -30. And so as pressure and volume fall, go to higher negative numbers, you get higher and higher ADH levels. And so when we have this non-osmotic release of ADH, this is what we're looking for. We're looking for a significant drop in pressure or volume, resulting in a very high vasopressin level. And if you then translate that and look at what its effect on urine osmolality and urine volume, you're going to get yourself peaked out with very high urine osmolalities and very low urine volumes. But take a look at our patient. The patient doesn't look like that at all. First of all, we reported they had normal blood pressure and on vital signs, and on exam, he had normal period perfusion. And then if you look at the urinalysis, his specific gravity is very low. This is not a patient who has a high ADH level. In fact, just the opposite. He has a very low ADH level. And so this is a bit confusing. right? Hyponatremia with a low urine osmolality is very unusual. If you kind of go through, the usual suspects of hyponatremia, heart failure, cirrhosis, nephrotic syndrome, volume depletion, thiazide-induced, SIADH, all of them have a high ADH, and so we'll have a high urine osmolality, and we'll have a high urine specific gravity. Hyponatremia with a low urine osmolality is special. It's rare. There's only a few cases. You have tea and toast syndrome, you have beer drinkers potomania, and you have psychogenic polydipsia. This is the full differential of hyponatremia with a low urine osmolality. Right, and this makes sense, right? Hyponatremia occurs when water in is greater than water out, and ADH decreases the water out. I mean, that's the role of it, and so it just makes sense that ADH is a person of interest in hyponatremia. Most of our patients are going to have that ADH, making sure that water goes back into the body rather than into the toilet. And so if you want to take a look at the determinants of urine volume, take the urine volume, and the urine volume is determined by the amount of solute that's excreted divided by that urinary concentration. Generally, if we think about kind of 24-hour data, and if we're not looking at patients in kidney failure, the amount of solute out is just going to be equal to the amount of solute in. And people on a standard Western diet generally have about 10 milliosms per kilogram for adults. And so if you kind of start throwing some numbers in there, that's going to give you about 700 milliosms as your solute load for a day. And the urinary concentration, that's one of the great things about the kidneys. It can vary dramatically, right? So if you minimize ADH and maximize urine volume, that urine osmolality is going to go down to 50, and that's going to allow you to produce 14 liters of urine with that 700 milliosms of solute. And if you maximize your urinary concentration, you crank it up to 1200 milliosms per kilogram water, that's going to minimize your urine output something around about half a liter or so. And that's going to be kind of the range that people are going to live in. And if a person were to drink 15 liters, which is beyond what a patient can generate, they're going to retain that last liter, and that's going to push their sodium down, dilute their serum sodium. But what happens when instead of eating 700 milliosms of solute a day, it goes down to 100 milliosms of solute a day? Well, in that case, even with ADH shut all the way off to zero, the maximum urine volume with that limited solute intake is just down to 2 liters, a volume that's actually pretty easy to exceed with just taking food in at a general rate. And so this is the pathology behind both tea and toast syndrome and beer drinkers potomania, where they just have a very low solute intake. And this is what was going on with our patient. Our patient, because of dysphagia and vomiting, wasn't taking any much solute, was still getting water through the PEG tube, and was essentially getting a psychogenic polydipsia by proxy. So, the disease in this situation is they have too low of solute. They have inadequate solute to get rid of the urine, the volume of water that they take in. And so the treatment is pretty simple, is to give solute. And this is what happened to our patient, right? So the question comes up, how much urine can a patient with tea and toast syndrome make in the solute contained in 1 liter of saline? And so you have 1 liter in, and they're going to make 6 liters. And the math is pretty straightforward, right? You have, if it's normal saline, that's going to be about 308 milliosms per liter. And we said that the lowest urine osmolality is 50 milliosms per kilogram water. And you just divide those by one another, and you'll get the 6 liters. And so this is what's so remarkable. And this is why our patient on that first admission to the ER had such a rapid increase in sodium. They were just starving for solute. And when we gave them the IV solute, they rapidly excreted all that excess water and normalized their serum sodium. So they sent the patient home, and 1 week later, patient develops very similar symptoms: altered mental status and nausea and vomiting. And the caregiver is like, wait a minute, I know what's going on here, right? I've seen this before. And they remember the diagnoses that were given in the ER. They were told they had a urinary tract infection, dehydration, and hypovolemic hyponatremia. They don't have access to antibiotics. They don't have any idea what hypovolemic hyponatremia means, but they do know what dehydration means. And what the caregiver started doing was giving additional water via the PEG tube and trying to help this patient's dehydration, what their self-diagnosis of dehydration was. And this goes on for about a week. And the patient gets actually pretty profoundly ill and returns to the ER. Now the patient looks quite a bit different. Blood pressure is 80/40 with a heart rate of 124. Temp is 102.4. Urinalysis now has a very high specific gravity, and the sodium, which had been low before, now is profoundly low. Additionally, the patient has very severe hypokalemia, profound metabolic acidosis, and acute kidney injury with the creatinine going from, I think it was 1.8 at discharge up to now 3.2. And this is a tough spot to be in, right? You've got a patient with septic shock, right? They got a fever, they're hypotensive, they're volume depleted, and you've got severe hyponatremia, and you need to weigh, how can I give resuscitation to this patient without causing osmotic demyelinating syndrome, right? And if you kind of go through the risk factors for osmotic demyelinating syndrome, this is all the risk factors that were come up in this nice review article in the American Journal of Medical Sciences. All kinds of risk factors. All the ones in black are ones that our patient has. So he has chronic hyponatremia. We think this has been going on for more than a week. The sodium is profoundly low at 102. He's got concurrent hypokalemia, and he's got malnourished. He doesn't have the liver disease, the alcoholism. We haven't raised the sodium too fast yet. That's still a possibility. Not on a thiazide, hasn't had a seizure, no hypoxia, no cancer. So again, osmotic demyelinating syndrome is just, it's an incredibly rare, thank God, complication of mismanagement of hyponatremia. It is a devastating neurologic disease. And essentially what happens is you have this rapid increase in the extracellular concentration causing a shift in volume from the intracellular compartment to the extracellular compartment. And that shift in volume causes the neurons to shrink in size. They pull away from their myelin sheaths. And when that happens, the myelin then necroses and dies. And you get this demyelinating syndrome. And it can be neurologically devastating and result in death of the patient. And one of the cruel, I don't know if it's cruel, but one of the things about osmotic demyelinating syndrome is it has a very characteristic MRI finding. And so I don't think we have this is not a situation where this disease happens and we don't find out about it. When this happens, right, these patients develop these neurologic symptoms, they all get referred to a neurologist, they all get an MRI of the brain, and you get this very distinctive signal in the pons allowing you to make the diagnosis. And so, I've never seen a case, right? I've got 20 years as a nephrologist, and I, thank God, have never seen a case. I've seen a lot of mismanaged sodiums, but thank God I've never seen a case of central pontine myelinolysis or osmotic demyelinating syndrome. And in fact, I work in a group of 20 nephrologists, and in my group, there's 2 of them have seen a case, and it was the same case, and they both saw it in fellowship. These diseases are really, really rare, but they do occur. And when they occur, they always surface because the evidence is easy to find on a standard imaging study, and they all go to court because it's an iatrogenic complication. They only get it from mismanagement of the treatment. So if this happens to you, you will be in a courtroom. So you want to be real careful. You don't want this to happen. And so we're just back to the basic question, how are you going to resuscitate this patient, right? So, I'm a little old school. I still kind of use the Rivers study on early goal-directed therapy. I'm looking at about 30 mils per kilogram for early resuscitation of sepsis. That's going to be a couple of liters of balanced solution for this patient. And what's our risk of increasing the sodium in that situation, right? We want, when we think about early management, they usually don't compromise for hyponatremia. And so you can kind of calculate what the change in sodium will be for any infusate of sodium. So probably the most famous review article on hyponatremia is this one by Androg and Matias. It's in the New England Journal of Medicine from the year 2000. And in that article, they introduced this formula. It's called the change in sodium formula. And all it allows you to do, it allows you to tell you what will the sodium be after I give 1 liter of an infusate. And so it's pretty simple. So you take the infusate sodium. So in lactated ringers, it's 130. You subtract out the serum sodium. In this case, it was 102. You then divide that by their total body water. It's always kind of a difficult hit and miss guess in the total body water. This is an elderly male. I used 0.5. That's always kind of a crapshoot. But, and then you add 1 to that because you're looking at their total body water after giving a liter. So you calculate the total body water, you add 1. And in this case, it comes out to 0.9. That means for every liter of balanced solution you give, this patient's sodium is going to go up by 0.9. And you look at that and you're like, you know what? That's actually probably fine, right? I can give this patient a couple of liters, complete my 30 cc's per kilogram infusion for my initial resuscitation. That's probably going to do him a lot of good. And so the sodium goes up by a couple of points. That's going to be fine. We'll still be able to keep under the speed limit of 6 per day, and we should be fine. The problem is that's not what happens to patients. So we're back to this figure. We're starting here. We're at very low volume or pressure, however you want to think about it, very, very high ADH levels. And as we start to resuscitate them, we're going to restore their volume. And what that's going to do is you're going to lose your stimuli for the release of ADH. And when that happens, now the body's going to have no stimuli for ADH, and urine volume is going to shoot up, urine osmolality is going to fall down, and you're going to have massive diuresis. And this is from a case series of patients very similar to this, looking at, what kind of urine output are we looking at? And so on average, it was 650 cc's of urine per hour. That 214 to 1200 are the 25 and 75 percentile. So 25% of people had urine outputs greater than 1200 cc's an hour. And so this is a massive diuresis once you've suppressed that ADH, and that's going to result in significant change in sodium way beyond what that calculation does from the New England Journal of Medicine. It doesn't account for any urine output at all. So you think maybe you're like, well, I'm going to be clever about this. I'm not going to give them saline. I'm going to start here, and I'm going to use norepinephrine to restore volume. And that doesn't let you out of this trap at all, right? Because it's not the infusion, it's not the resuscitation fluid that's the problem. It's the fact that you've restored perfusion. So even if you use norepinephrine to restore perfusion, you still get the suppression of ADH, and you still get the massive urine output. It doesn't leave you out of this trap. Now, you may get lucky, right? This patient's got some acute kidney injury, and the acute kidney injury can be your friend, right? Because if they have oliguria, well, then you can give them all the resuscitation you want, and as long as they don't have this massive diuresis, they're not going to rapidly increase their serum sodium, right? They're not going to jump up with following that infusion. They'll be much more similar to that equation that you use with the Endrogue formula from the New England Journal of Medicine. So you can hope that this patient whose creatinine went from 2 to 3 has significant enough AKI that they're actually not going to be non-oliguric. But that's kind of a crapshoot. And I think we've all seen plenty of patients with creatinines of 3 have plenty of urine output. And if that happens, you're going to get into trouble. And so there's 3 strategies. And so the first one is kind of you start with your resuscitation fluid, whether it's normal saline or lactated ringers, and then you keep D5W or PO/PEG water available, and you just want to match their urine output once they start developing a lot of urine output. And so if you kind of look at it on the graph, you start in this area, you start to resuscitate them, and once you do that resuscitation, you need to give them a tremendous amount of fluid to recover. I can't actually see this part of the slides. It's very hard for me to run the animations. So you need to give them plenty of volume, plenty of fluid. You need to be prepared to be able to give them 1 to 2 liters an hour in order to prevent the rapid change in sodium, which is going to be difficult to do. The second strategy is similar. You give them normal saline or lactated ringers, your resuscitation fluid. You have water ready to match urine output, but you're going to give them DDAVP once that urine output starts. So what you're going to do is you're going to prevent that urine output from shooting up to be 1.5 or 2 liters an hour. You're going to suppress their urine output with the use of DDAVP, so it's easy to keep up. And so what does this look like? Again, you start with your low perfusion. You give them the resuscitation fluid. And then you give them the DDAVP. And then that restores their ADH back up to a very high level, suppressing their urine volume. And this is not a bad solution. It is a reactive strategy, though. You are waiting for your resuscitation to generate all of the to suppress the ADH and increase the urine output. And at that point, you react to that and you can fall behind. The last strategy is called the DDAVP clamp. And this one, you start in the same position. You have the low perfusion, you have very high ADH levels. But before you give them the resuscitation, you load them with DDAVP. And then once you give the resuscitation, it doesn't matter because their ADH levels stay high, and you can restore their perfusion without worrying about that massive water diuresis resulting in a rapid increase in sodium. And so this is a prospective way to stay in front of this problem. Now, one of the consequences of this is essentially you're giving them iatrogenic SIADH. And one of the truths about SIADH is that you can't increase their serum sodium with an isotonic or crystalloid. So if you give these patients normal saline, their sodium is not going to get better, right? So once you do want to start raising their sodium up, you're going to need to give them 3%, something that has a much higher sodium concentration. So there's a lot of commitment here. You're going to be keeping their sodium down low until you use 3%, but it will prevent that rapid diuresis and rapid increase in serum sodium. There are your the three different strategies. I'm a big fan of either the DDAVP rescue or the DDAVP clamp. What's the speed limit that we're looking for? We're looking for 6 millimoles per liter change in the serum sodium in the first 24 hours and 8 millimoles per liter in subsequent days. How well does the DDAVP clamp work? This is a retrospective study from Rochester, Richard Stern's group, looking at 40 or 50 cases that they use the DDAVP clamp, and they're looking at their change in sodium. This is graphed against their pre-treatment sodiums. The red lines are kind of your target sodium, so that's 6 at 24 hours and 14 at 48 hours. And you can see they generally do a pretty good job. They went past their targets a little bit, certainly more so in the first 24 hours. They did a lot better in the second 24 hours, but it seemed to be a pretty effective system. They had no cases of ODS. And then this is kind of just an aside. In addition, if you do blow past your target sodium, the current recommendation is that you do relower them, especially if they are at high risk for osmotic demyelinating syndrome. And the only way you'll be able to relower them, you can't give them enough water if they've been able to suppress their ADH. You really need to give them exogenous DDAVP to be successful at relowering their serum sodium to reach your targets. And then the last thing I want to leave you with, because I think this is understood or not appreciated nearly enough, is that hypokalemia is a really important risk factor for osmotic demyelinating syndrome. And it's not some kind of magic about, this hypokalemia just adds to the risk. It's probably because when we replace the potassium, we don't think about that giving potassium is really equivalent to giving them sodium, right? Because that any potassium we give is immediately exchanged, moves intracellularly, sodium moves out of the cell. And so whenever you give potassium, you're actually going to be giving, it's effectively equivalent to giving sodium. And so this is just a case report from a number of years ago, and it was a patient who came in with a potassium of 1.6, and not surprisingly, they got a ton of potassium in the first 24 hours, 430 milliequivalents of IV potassium chloride in the first 24 hours, and then 200 milliequivalents in subsequent days. And that's equivalent to 4 liters of normal saline in terms of its osmotic load and the change in the tonicity that you're going to get with that potassium. You need to respect the amount of potassium you give. It's important, right? Because if you think about, oftentimes the people that are governing or following the sodiums and following the 3% saline and making those decisions aren't the same people that are worried about the potassiums. And that's not a good division of labor. That should be one team and only one group dealing with it. That's the story I wanted to give you. That's what I have. I'm happy to answer questions, but it's a nice, tidy little case report of psychogenic polydipsia by proxy. Thank you.
Thank you, Dr. Toff. Dr. Panig has had to step out. He's presenting at another meeting, but thank you so much. Even dealing with this day in, day out, I still continue to learn a lot from you. I think people probably don't know, I actually met Dr. Toff when I was an intern. And we've had a lot of animated conversations about kidney and blood. But guys, if there's any questions, you could please put them in the chat box and we'd love to answer that. And while we're waiting for questions, I'll let Dr. Gulati, who is our governor for ACP, say some parting words in the meantime. You're unmuted now, Dr. Gulati, I think.
Great, wonderful. Thank you very much. And thank you, Dr. Levin and Dr. Toff, for fascinating talk. And I thought I knew everything I wanted to know, but apparently I don't. So thank you for that. Some really great pearls and clinical pearls that we can take back to the bedside. So thank you. I want to thank Dr. Kant and Dr. Janaki, Deepak for kind of arranging this, and I think this is a great high yield topic for all of our ACP members. So thank you.
Thank you, Dr. Gulati.
Yeah. So Dr. Toff, there's a question there about how long do you keep patients on the DDAVP clamp?
Yeah, so I mean, I think the important thing is remembering what you're trying to do. You're trying to prevent these patients from developing osmotic demyelinating syndrome. And if you take a look at most of the retrospective data, very few of these cases happen when the sodium is greater than 120. Almost all of them are below 115. And so that's generally what I do, is I use the clamp to get them above 120, and then I stop the clamp and manage it on my own.
Excellent. So if there are no further questions, I'd like to thank Dr. Levine and Dr. Toff, and of course, all of the ACP group. A special shout out to Ted, who is our AV expert. And of course, we couldn't do anything without Mariette Ellen. She's pretty much the lifeline of ACP. But above all, I have to also say, Dr. Toff and Dr. Levine, thank you so much for taking the time. Really, this was amazing, and we hope you'll be back again.